I would like to welcome Dr. Elisa Puzzolo, University of Liverpool. Please, Dr. Puzzolo.
Thank you, everyone. A pleasure to be with you all today. And it's a pleasure to kick off this first panel discussions talking about respiratory disease with a particular focus on air pollution that we also heard quite a lot this morning. So I will start with some introductory reflections, some learning about how air pollution is connected to health and the major health impacts, and then present a concrete case study, an example of how training of health professionals has taken place, with some learning from Africa, which I think are going to be quite inspirational. But starting with some of the latest data on air pollution, we heard statistics mentioning 7 million, and some of the most recent statistics are even gone up. You might be surprised to see that actually air pollution has now taken as the leading cause of global disease, overtaking both high blood pressure and smoking, if you look at the panel on the right-hand side. And in terms of mortality, air pollution ranks among the top 3 causes and is only second to high blood pressure. So this data is striking. We think air pollution is something far away, but actually this demonstrates that all of us globally are highly exposed to this environmental hazard. And so some of the latest data account for 8.1 million total premature deaths accountable to air pollution. And of such deaths, just over 700,000 occur in children under the age of 5. And this is particularly the case in countries like South Asia and Sub-Saharan Africa. Air pollution is a global problem. It affects both global north and global south countries. And we know it's related to a lot of increase in hospital admissions from respiratory conditions, as well as other diseases. And you might have heard that World Bank has created some clear estimates, and actually is up to $8 trillion a year are due to air pollution costs because of the health sector costs that are equivalent to almost 6% of GDP. So very striking data. So something I hope that will be a key takeaway message from today's discussion, from my presentation, is this last bubble. The air quality must be considered alongside other risk factors, traditional risk factors like smoking or hypertension and dietary habits, as part of medical consultation assessing patients' risk. And we all have experienced a moment of exposure to air pollution. We know what it means to be in polluted air. And the sources of contaminations are obviously transport, like the diesel emitting vehicles and gasoline in general, as well fossil fuel burning, industry burnings. But in reality, if we think of the global south countries, there's a lot more. Open waste burning, agricultural practices, again, where crop residues get burned, and very importantly, the reliance of biomass for cooking and household energy needs that affects lots of people. And you'll hear more about that. So the pollutants that are emitted from all of these different sources include variety. We heard this morning, we're talking about particulate matter, carbon monoxide, nitrogen dioxide, as well as polycyclic aromatic hydrocarbons, for example, that have been shown to create carcinogenicity. And the way the pollutants operate, they go down, deep down into our lungs, and some of them, which are smaller inside, like ultrafine particles, can even reach the bloodstream. And as you can see, these beautiful illustrations, this is not just a problem for the elderly or the children. Even the developing fetus is very negatively affected by exposure to air pollutions when pregnant mothers are exposed. And it's been demonstrated, and you see in the next here on the summary table, how the main long-term effects by different pollutants are primarily responsible for a wide range of conditions. And if we look at particulate matter, fine particulate matter, PM2.5, the evidence is quite striking. And it's not just respiratory conditions and, for example, development of COPD and decreased lung functions and lung cancer, but it's also cardiovascular diabetes, as more recently, as we were saying this morning, the risk of dementia. And for exposure to carbon monoxide, a lot of us have a smoke alarm alert in our homes. it's a high increase in risk for lower weight, for example, in children. But now, to finish off on these introductions, I'd like to spend just final reflections on house arrest pollution. This has been a topic I've been leading for 15 years. I've worked at WHO, the World Health Organization, on characterizing more the exposure to house arrest pollution. And as you can see in this image in the middle, with that woman from Guatemala with her baby on their backs, this is a daily activity that millions and millions of women in low and middle income countries are doing daily. They're feeding their families and they're using an open fire or a traditional stove, still burning firewood or burning charcoal indoor. And that amount of smoke that they inhale, it's equivalent to burning 400 cigarettes per hour in the kitchen. Can you imagine? So this is the amount of exposure that some people get. And again, the global burden of disease for house arrest pollution is similar type of conditions. Plus all the drudgery, for example, for those women and teenage girls that have to go and collect the firewood, for example, and the risk and loss of productivity time. So with that introductions, I'd like now to move on and tell you more of a case study, an example of how primary and secondary prevention has been made possible in sub-Saharan Africa with a project that has been led by the Cleaner Africa group. Cleaner Africa is a global health research unit that's been funded by the UK National Institute of Health and Care Research with a program over 5 years, over £7 million. And it focuses on the clean energy access for the prevention of non-communicable disease in Africa. And I had the honor to be one of the co-directors for this initiative. And this partnership is made up from academics, clinicians, public health practitioners, and economics. Actually, there's colleagues from University of Dar es Salaam Department of Economics across 5 countries: Kenya, Cameroon, Rwanda, Tanzania, and Uganda. And the reason why I'm presenting this case study is actually an amazing work being done in Kenya in partnership with the Ministry of Health, where the topic of house arrest pollution has become so tangible that together with the Ministry of Health, we prepared a training module to train community health workers. This is a key figure for some of these countries. In Europe, we don't have much of these health promoters. But actually in Sub-Saharan Africa and in India and lots of low and middle income countries, this figure are the first individuals dealing with the communities, supporting and bringing the health promotion messages, explaining what the risk of disease is. And so targeting these community health workers means finding ways to reach millions of individuals at the country level without necessarily having the need to go and meet with medical practice, the GPs, which might be far away, for example, for some of those communities. And so here you can see the moment of the launch of this training guide. And this is a big book, but the actual manual is a normal size. The unveiling of the book, where this training module was at the end of the pandemic, was launched. And the training module is called the Community Household Air Pollution Prevention Program, CHAPPP, and has been empowering community health workforces in Kenya through educations on the topic of house arrest pollutions and air pollutions in general, and really supporting health prevention messages to decrease ultimately the burden of air pollution related disease. The way the training has been developed is through the use of job aids, flip charts, that you can see in this image. This woman with the mask was one of the trained community health workers. She was also part of our group, basically meeting with the community members and showing the different units, basically how the training module covers understanding of the type of fuels and technologies, for example, are most polluting, and then what are the health impacts of using such technology, and reflections, for example, on the risk of burns. Because you think using an open fire is normal, it should be with no harm, but actually children are falling on open fires, and mothers also with their dress can catch fires. So just recognizing that breathing, inhaling that smoke, which in some culture is actually helping to remove mosquitoes, or they believe is something positive for their health, it's not. And so through that training and the use, for example, of QR codes, with that code you see a little bit that explains the exposure to carbon monoxide poisoning. It shows you that if you're keeping a charcoal stove in your home, for example, to keep warm inside, you're actually posing your family at risk of carbon monoxide light poisoning. And so some little videos and explanation, and ultimately it's not just harm minimization, how to reduce exposure, but actually it's primary prevention. How transition to a cleaner technology and fuels can help and benefit the health for your family and the individual. And so this work has been quite a tremendous success. At the moment, we are working with the government for a national strategy to reach all of the 130,000 community health workers in the country, and ultimately reaching all of the Kenyan populations, over 50 million Kenyans. And on that particular picture I chose intentionally, it shows a woman from a nomadic population, the Maasai. Even the more hard-to-reach groups, basically, started to receive the messaging because the training module was part of the national curriculum. When we say module 14, it means that community health workers in Kenya, they are trained on WASH, so water and sanitation, they're training on infectious diseases, and now they also have the opportunity to be trained on prevention of hazard air pollution, and therefore understanding ways that ultimately people in their home can then reduce that exposure to pollution and disease. And with some impact evaluations led by the Cleaner Africa, we already witnessed that within 1 or 2 months for training, it was 85% of behavior change, so harm minimization in the way people were cooking, for example, moving the stove outside if they have the opportunity, not just cooking indoor, trying to keep the children away from that direct exposure, as well as an increase in uptake of cooking and overall cultural change. And finally, I'm pleased to say that now this CHAPPP, this Community Housing Air Pollution Prevention Program, is currently, we are in discussions, for uptake in Rwanda, Uganda, and Cameroon. This has been launched, but again, we want this to be a national rollout, with a lot of dialogue with the individual Ministry of Health, translations of the materials according to the local context, plus the local language. So there's a lot of work going behind the scene. But if this example can inspire us in Europe, and so that if in Africa have managed to put a curriculum as part of their national curriculum, why we can do something similar for medical professionals and others, in the European context. So I hope this was inspirational. Just a couple of final slides in terms of key takeaways. That air pollution is an issue of health equity, because the most vulnerable populations that are affected to exposure to air pollution are the children, the elderly, and people with the lower socioeconomic status. So I will never stop reinforcing that message, how this work is related to health equity. But also we discussed extensively this morning this climate and health connection. How it would be amazing to equip and train physicians, clinicians in understanding these links of impacts, for example, because a lot of the air pollutants are also greenhouse gases and are also impacting climate change. We heard extensively of super pollutants, black carbon, methane this morning. Therefore, physicians can become advocate for healthier, more sustainable, greener cities and spaces for their communities. And finally, an important point, we shouldn't reinvent the wheel. There are already some good training materials out there, and here I'm emphasizing the WHO Air Pollution and Health Training Toolkit. So the information is out there, and the same for climate change. You just need to pull out for those training modules and create something, and could be a little package, that could be added as part of other national curriculum for medical students and others. But a lot is already there, just picking it up, compacting into something that could be easily transferred. And final reflections on the clinical applications, given a lot of you in this room and a lot of in the audience are clinical experts, that taking the environmental exposure history, understanding if individual, the patient, a doctor has in front of himself is exposed to industrial pollutions, to areas of high traffic, for example, would be very easy. It's as simple as asking about dietary habits. But this is not done. And asking and counseling patients on ways to reduce their exposure, for example, how to keep the indoor air clean. We think that burning biomass indoor for heating with these fancy pellet stove, for example, is very nice, but actually there's a lot of indoor pollution coming out from those stoves. Similarly, peak times where the traffic or high air quality alerts are issued. There could be recommendations to reduce, for example, exposure to tropospheric ozone. The children shouldn't go play in playgrounds when such alerts are issued. And finally, recognizing air pollution related exacerbations, like in the case of asthma. And at the very end of my reflections, I also think that physicians, the health practitioners, are so well respected. They should play and become more and more having an active role in policy advocacy, promoting cleaner laws, cleaner zones, and urban planning that really ultimately make the best for their communities, supporting the communities in a way that their intervention are really tailored to the needs of that community, the risk of that community. So on that message, I hope this was interesting and inspirational, particularly learning from a very different setting. Thank you.
Thank you very much.